So thank you very much. Good afternoon. I would like to speak to you this afternoon about biomarkers in the context of surgical therapy for metastatic kidney, bladder, and prostate cancer. And as we've heard up to this point, there may be something to talk about in the context of kidney cancer, but really for prostate cancer and bladder cancer, we're not really doing a lot of surgery. So I will stray a little bit from my official mandate and talk in general about markers for metastatic disease. One of the key challenges up front when we're dealing with tissue biomarkers is the issue of sampling. So for sampling the primary tumor, how does that reflect the biology of the metastatic disease? Tumor heterogeneity, of course, is always a problem. If we're, for example, biopsying with a couple of cores a primary kidney tumor, how does that reflect the metastatic sites or even the rest of that kidney tumor? And then we have evolution over time, particularly with treatment, that the biology of, for example, metastatic castrate-resistant prostate cancer is quite different than the biology of the primary tumor. So let's talk about kidney cancer a little bit. I think here the question is really which patients have tumors that will progress rapidly despite optimal therapy. So if they're going to progress anyway, then we're not going to do surgery, and if they're not, then we would consider surgery. There are various criteria that we might use to perhaps decide that a patient's not suitable for surgery. This is a list outlined by Chris Wood. There are the Heng criteria that stratify risk in general for patients, or before this, the Motzer criteria. They give a general direction, but not really the specifics. I think what we really need are some drug specifics, or with the new targeted agents, some drug specific markers that reflect the biology and really help us make treatment decisions. There's a long list of potential markers. I'm not going to go into all of these by any means. An example is, for example, VEGF receptor 3, which Brian Rinne and colleagues looked at in patients who were getting sunitinib after failing bevacizumab, and they showed a clear correlation with patient outcome. But this marker, as so many others, never get beyond the discovery phase and never really reach a point of being clinically useful. And this is something we're going to need to overcome to help design more personalized treatment. A very attractive marker right now, and sort of a hot new, in the context of a hot new drug, are the PD-1 ligand and its relationship to PD-1 inhibitors. And the first trial that was published in the New England Journal showed this very compelling figure here, that patients who were ligand negative did not respond, whereas those who were ligand positive had a reasonable response rate. This, of course, generated a lot of interest. It has been, this was not only kidney cancer patients, by the way, but several other cancers. This was validated in a larger cohort, and while some ligand-negative patients clearly do respond, there is a correlation between the expression and important disease outcomes. A very interesting study done by a group in Connecticut, they matched approximately 40 patients. They had 4 cores of tissue from the primary, and they had tissue from metastatic sites, and they looked at ligand expression, and they did a quantitative immunofluorescence to measure the ligand expression. And they not only showed higher expression of ligand in the metastatic sites, but most importantly, they showed great heterogeneity in the primary sites between the 4 cores, and they showed very poor correlation between the primary and the metastatic sites. So it just highlights the limitations of some of these tissue markers in metastatic disease. Kidney cancer, there's a lot going on right now. It's not necessarily my area of expertise, but one study just to highlight, a multi-center European study where they're really doing a comprehensive genomic profiling of kidney cancer that is likely to lead to significant improvements in the near future. In bladder cancer, you could say there's where there is nothing, there's the most to gain, there's the most progress to make, and I think bladder cancer is a particularly fertile ground right now. There's a lot happening. We saw in October of 2013, there were 3 papers on a novel mutation, STAG2, in bladder cancer, all in the same issue of Nature Genetics. This was followed then in January by this paper from the TCGA, the Cancer Genome Atlas, which looks at comprehensive molecular characterization. It was followed just a couple of weeks later by this paper from MD Anderson describing intrinsic subtypes of bladder cancer, much like the subtypes we see in breast cancer based on gene expression profiling. And a day later, another high-profile paper from UNC. And all 3 of these latter papers come to the same conclusion that bladder really is made up of different subtypes on a molecular basis, and this parallels quite closely the breast subtypes, basal and luminal, with potentially different subgroupings. The MD Anderson group has shown that this correlates with outcome. The basal tumors are highly proliferative and generally do more poorly. There are very clear biology correlates to this that really divides bladder cancer into almost separate diseases that need to be studied separately. And if we're able to do that, we're more likely to arrive at better targeted therapies as well as better biomarkers to predict outcomes to those therapies. Not only does this give us some indication of potentially where the tumor has arisen from, whether it's a luminal cell or a basal cell, it also potentially gives us correlations to treatment. And this is, I think, the most compelling part about this story right now, is that the MD Anderson group has shown that the P53-like group, as they're calling them, do not respond to chemotherapy. And this we can immediately translate. This has actually been validated in a couple of other centers, that these patients will not respond to neoadjuvant chemotherapy and should probably not get neoadjuvant chemotherapy, and the basal tumors respond the best. So there's a lot happening in bladder cancer. Prostate cancer, as Neil Fleshner alluded to, we are starting to think about surgery in the context of metastatic disease, particularly patients who present with oligometastatic prostate cancer, or those who are found to have a localized recurrence that's potentially amenable to surgery. We're nowhere near discussing markers in those patients, but in general, in metastatic prostate cancer, there are a lot of drugs, just as there are in kidney cancer, and a lot of work is being done on biomarkers. I think here there's a great emphasis on liquid biopsies, and I think this is, to some degree, the path of the future. We get around some of the issues of tumor sampling and tumor heterogeneity by having a marker that reflects the biology of the whole tumor. Liquid biopsies are, for the most part right now, circulating tumor cells, but cell-free DNA has also been proven recently to be measurable, and then there are also microparticles. The idea is any bad clone or any specific clone in a tumor somewhere will be reflected in the serum or in the blood of the patient. You're all familiar with the cell search device for isolating circulating tumor cells, and we know that baseline counts predict outcome, just simple prognosis. We also know that changes in CTC counts correlate to treatment response, so it's also a predictive marker. But it's a fairly blunt tool. It's based on EpCAM expression only and ignores a lot of the other biology going on. A lot of patients do not have circulating tumor cells by this technique, and you cannot do a lot with the cells as far as elucidating further mechanisms and further markers. We've developed a novel device, and there are multiple novel devices out there. Ours is based on microfluidic separation, where rigid cells will not pass layers of obstacles, of constrictions, whereas the more deformable cells, in particular the white cells, will move through, and we end up with a relatively enriched population of circulating tumor cells, which we can then take and analyze for specific markers, whether it's protein, transcriptomics, genomics, whatever we want. It's just what the device looks like. And just as proof of principle, we show here in about 50 patients that we're finding a lot more circulating tumor cells with this device than with the cell search device. We have a series now on the very left-hand side of this are normal controls. Over here, we've done about 15 now, and none of our normal controls have any CTCs. So what do we do with these CTCs? Well, counting is the least interesting part about it. Actually measuring the biology is the most interesting part. And you can have a patient as he progresses from one treatment to another in the metastatic prostate cancer setting, and you can draw blood whenever you want. You can look at the biology. You can figure out what's going on in a longitudinal fashion and adjust your treatment appropriately. This is another example of the same. This is Colin Collins is in our group in Vancouver, who's looking at cell-free DNA. So we now have the technologies to isolate DNA from the serum of patients with metastatic castrate-resistant disease. We can do array CGH, which looks at copy number, variations. So you can see I've just taken the headings over here to make it easier to read. But you can look at things like MYC amplification, androgen receptor amplification, and we've also done sequencing of part of the androgen receptor and looking for specific mutations. And this is very interesting work because it shows mutations arising in patients on enzalutamide, for example, as they become resistant to the drug. And so you have a very dynamic process here. Also, androgen receptor amplification occurring as patients progress on treatments. So there's a lot of promise in these techniques. So in summary, the role of biomarkers in metastatic kidney, bladder, and prostate cancer, I think we are just starting to scratch the surface. We need to move beyond just marker discovery and actually validate some of these tests in larger patient cohorts. We need tests that address tumor heterogeneity. They should reflect some of the tumor biology. They need to consider the dynamic changes in tumor over time. And I believe the most promising tests employ the various omic technologies in liquid biopsies. Thank you very much.
I have one question. I mean, it took 11 years to finish a randomized trial of performing neoadjuvant chemo with cystectomy. And you have so many markers, so many tumor subtypes. Do you think how it
specifically in bladder? But, yeah. Well, I don't know. I think if we have, if we're able to enrich our patient populations for patients who are likely to respond, we're going to get a much better signal, and I think it'll be more compelling to the treating physicians to actually enroll their patients in trials. I think, as if we can do it intelligently, if we can design trials intelligently, I think we can reverse our very poor track record of getting any trials done in bladder cancer. I don't think we can throw in the towel.
Thank you. Thank you again to Dr. Klotz and Roman for putting this meeting together.